Okay, so we have successfully made it through another round of small group topics, and we're going to do I'm starting late, but it's okay because I bet you I barely have more than 4 minutes worth of slides here. So we should be fine. For the next section, the idea was to maybe split out into some slightly different topics and even talk about some things that aren't about opioid use disorder in general. So for that, my hope was actually just to set up a couple different patient scenarios, have you think about those patient scenarios and think about which of those are most interesting to you, and then the groups are set up somewhat to talk around those type of scenarios. So I guess I should have introduced myself. I'm Brad Riley. I work at MSU Spectrum Health in Grand Rapids, Michigan, which is West Michigan. And I did emergency medicine and then medical toxicology and then addiction medicine, then again on top of that. So let's talk about a couple topics that are maybe slightly more advanced, but the thing is we've had such good small groups that I know that my groups have talked about some of these type of patients already. So first one up, and disclosures. I do have a couple of small grants through Michigan Opioid Partnership, through their SAMHSA grants, that are helping to either initiate naloxone in the emergency department or to find follow-up clinics for Suboxone, and also want to start an inpatient addiction medicine service. I'm sorry, I did not actually disclose those officially before this, but there will be no I don't think I have any conflicts of interest, actually. So, all right, so 37-year-old man presents with an abscess on his left forearm. You're performing the IND. He discloses to you that this is secondary to injection drug use, and he would like to start Suboxone. You have a risk-benefit discussion with him. His last heroin, he says, use was 16 hours ago. You give him one strip of an 8/2 milligram sublingual, and 15 minutes later, the patient's nurse asks you to come see him because he kind of looks bad, she says. He's vomiting, he's rolling around in his bed, his heart rate's 115, blood pressure is elevated, he's sweaty, he's agitated. What's going on, and what treatment, if any, is necessary? This wasn't really supposed to be an interactive part of but I guess it is. What's going on? So this is Precipitate Withdrawal. We're going to have some tables that talk about Precipitate Withdrawal in this type of patient and what to clinically do in these situations coming up. All right. Next idea, or next topic. 19-year-old male. He arrives from EMS from a local house party. They were called when some of his friends noticed that he was not acting right. This is always how it is. People always have these very descriptive terms when they talk about. So you see him. He's tachy. He's hypertensive. Increased respiratory rate. His temp's 38.1. His pulse ox 92%. He looks agitated. He's confused. His pupils are dilated. Poorly reactive. He's sweaty. He's erythematous. His friends arrive and say that he's been using Molly. Nothing like this has ever happened before. So what is Molly? What's Molly in your neighborhood? MDMA? Okay, so Ecstasy. Do you think that's what this patient used? I see head shaking. What does it normally look like when somebody uses a little Ecstasy or something? E? Maybe this, but not this. Not this much, right? So treatment recommendations, priorities. Okay, so this looks more like somebody who's floridly sympathomimetic. This looks like more than just Molly. So talking about advanced topics in amphetamine use, methamphetamine use, even bath salts we could throw in there if somebody wanted to talk about that, is going to be one of the other groups. And I think they also want to focus on what do you do when the person comes in and they don't just have opioid use disorder, but they actually have combined stimulant use disorder, and how are we going to address that too? Okay, next advanced topics that we'll be trying to discuss. 45-year-old woman presents late on a Sunday night. Chief complaint is belly pain. She reports body aches, nausea, vomiting, diarrhea, diffuse abdominal pain. She yawns multiple times during her exam. She's anxious, and she can't sit still. Vital signs are there for you to see, maybe a little hypertensive. You get a CMP, she has some mildly elevated AST and ALT, some hypokalemia. You give her a liter of fluids and some Zofran, and she says she doesn't feel much better. At some point, it kind of slips out that she's a local patient at the methadone treatment program, and she may have missed her dose of 120 milligrams on Saturday and Sunday. So what is this? This is just opioid withdrawal. And it's funny because we actually just talked about this in the last group we had. Can you confirm her dose? If you can't, should you order some methadone for her? What other treatments could you offer her if you don't want to give her methadone? And so, once again, advanced topics and methadone will be one of the tables to talk about more about this. And last one, we have a 52-year-old guy. He brought in by his family, and they say they've had enough of his drinking. He admits to consuming about a pint of vodka per day, and states that he gets the shakes and severe anxiety if he doesn't. He's never been in treatment before, but he feels like he is ready. His last drink was 8 hours ago. He says he's craving one now. Here's his vital signs. What treatment options are available? What about giving him naltrexone, camprosate, disulfiram? Are you going to do that in the emergency department? What else could you do for this patient who looks like he has alcohol use disorder?